Okay, it is 1:02. Let's go ahead and get started. Welcome everyone to Kids in Crisis. When is hospitalization needed? This is a partnership webinar between Marshall University School Health TA Center, Highland Hospital, and River Park Hospital. We've known some of these folks for more than a decade, and we're really happy to have them here today. We have a nice, diverse audience, and we decided on this webinar because this is one of the most asked questions that we get when we visit schools and communities is, how do you know when to call a hospital? And when you do call a hospital, how do you know what to say or who to ask for? So we thought that Leslie, Brad, and Chad and Angela might be able to help us out today. So welcome. We are not hosting CEs. This is informational only, but we are recording for a few folks who couldn't get out of their school rooms today and out of their settings to join us. So it will be up on our website after this at wvesmh.org with a link to probably YouTube. And on that note, I am Tiffany Pittman, School Mental Health Coordinator, Marshall University School Health TA Center. With me, I have Crystal Criswell. She's my teammate and partner in crime. She's a school health coordinator also at Marshall. And from River Park Hospital, we have Leslie Clagg and Angela Wilks. And from Highland, we have Brad Story and Chad Clagg. They will introduce themselves more directly. This is because we don't have a huge audience. We have less than 100 folks today. So we will have a robust Q&A, I hope, toward the end. But I'm going to try to share yours, Leslie. Go ahead and share Leslie's presentation. And
while you're doing that, I have a couple of mystery people on here. If your username doesn't identify your actual name, please put in chat who you really are. There's a couple of them, Abark and Jean. I don't know who you are.
okay. Okay. Leslie, I'm going to try to share this and then I'm going to try to do presenter view. Let me know if this shows up correctly because I can't see it anymore. Does it show up correct for you, Leslie? Big, huge screen? Or do you see the presenter view that I see? Oh, you're muted, dear.
I can see it. Yeah, it shows up.
Okay. All right, I didn't want all the notes and everything fun. Okay, so as we get started today, I think we have enough folks in. We're gonna go ahead and started. Please do sign in the chat with your name, your agency, and your role so we can know who's here. If you need an attendance certificate at the end of this, email me. I'll put my email. Crystal can put mine and her emails in chat. We're happy to give you an attendance certificate if you need one for your organization. Otherwise, let me turn this over to Leslie Clagg from River Park Hospital.
Hi, everybody. As Tiffany said, my name is Leslie Clagg and I am with River Park Hospital. I do referral services here at the hospital. And I have with me in the background here, Angela Harrison. Angie Wilks will also be up here in just a moment. She is our admissions director, but Angela Harrison is our director over all of our children's services. So she does all the services from acute and residential, 30-day, all of that for us. Okay, so let's go ahead and get started. Today we're going to present on psychiatric hospitals, basically what constitutes an admission for your youth in crisis. And we at River Park as well as Highland have some information for you today so that you kind of get a better idea of what to expect or what you need in order to make a referral that would potentially be admitted to the hospital. The first thing I'm going to start with is, and Tiffany, I'm going to skip over our acute real quick, but I'm going to talk about that right there first, that first slide. So the services that we have available to youth in crisis here at our hospital, we have acute services, which is a short-term stay. We have subacute services, and those services We have a diagnostic program for our adolescent population. And then we also have a program for our substance abuse adolescents. So you can go to that next slide for me. So skip that one. And I think you're going to skip like the next three, Tiffany, sorry. And one more. I'm sorry, two more. There we go. Okay, so the subacute services that we offer here at the hospital are typically a 30-day stay, but not always 30 days. So we have a 30-day chemical dependency program, like I said, and a 30-day diagnostic program. Okay, you can go to the next slide. For the 30-day chemical dependency program, we're looking for male and female ages 12 to 17. They must be in DHHR custody, and it does require a court order for that program. We look for an IQ to be at least 70 or higher to be appropriate to be able to do those services. The average length of stay for that program is 30 days, but it could be potentially less if we feel that they've got the information that they need in that time frame. Okay, and then they would also have to have an MCM1, and that's done by a physician. And that basically is just something that shows what the medical need is for that child, that they need to be there for that service. Okay, you can skip the next one. Then we have our diagnostic program, and that's for male and females ages 8 to 17. That does require a court order as well, and they have to be in state's custody for that program. Again, same thing, high IQ of 70 or higher, and then your average length of stay is about 30 days, but it could potentially be less. And that would be based on if we have a large number of kids in the program, or we just have a few, we may be able to complete some of that testing a little quicker. Same thing with this, it does require that MCM1. And then that information on your screen there just gives you contact information. You would contact the admissions department, and that's Angie Wilks. There's the phone number, fax number, and email address to send those referrals to us.
And we will send out the PowerPoint after to all attendees. So you don't have to frantically scribe if you don't want to.
Okay, so we'll move on to the next program. I want to get through these because really what your all's focus is the acute, but I just want to give you a brief information on our residential programs. We have 3 residential programs. We have the Bridge program, which is abuse reactive services for our younger children, and that's ages 7 to 12. We have Roundtable program, which is a sex offender specific treatment, and that's for males, and those are ages
12 to 17.
12 to 17. And then we have Barbersville School. Okay, you can go to the next slide, Tiffany. All right, so a brief description of the Bridge program. It's a 15-bed residential treatment program for both male and females ages 7 to 12. Again, this is another program. We do require that IQ to be at least 70 or higher. The average length of stay is about 6 to 12 months for that program. And again, that MCM1 is required. The Bridge program is designed for kids that have been emotionally, physically, and or sexually abused, and they are really having trouble coping, and they're acting out on different behaviors because of their trauma. All right, and then Barbersville School. For that program, you have to have a major psychiatric disorder and failures in less restrictive environments. So like an example of a major psychiatric disorder would be major depressive disorder. We can't take diagnosis like NOS, the things that are not otherwise specified or something like that. We do need maybe PTSD, post-traumatic stress disorder. So some of the more severe psychiatric disorders is what we look for Barbersville School. That's a 22-bed residential unit, both male and females. We have 3 different cottages, and we take kids ages 12 to 17. The average length of stay for Barbersville School is about 5 to 6 months. It could be longer, it could be a little bit shorter. It just depends on how motivated they are to do that program, and basically how much is going on with them, what severity of the psychiatric disorders they're dealing with. That does require a court order as well. And Bridge does not necessarily require a court order. Sorry, I didn't touch on that last slide. All right, and then the next program that we have residential is Roundtable Program. That is our sex offender specific treatment program. That is for males only. That's age 12 to 17. The average length of stay for that program is 18 months, but it could be shorter or it could be a little bit longer. Again, IQ requirement is 70 or higher. They also do not have to be court ordered into the program. I know a lot of people ask about whether they have charges or not, and they don't necessarily have to have those, and they don't necessarily have to be court ordered. We just have to know that they are at high risk. Okay, so these are the contact information for all of those residential programs as well. It's basically, it's the same thing as the 30-day programs and the subacute programs. You would contact Angela Wilks, who just walked in. You guys scoot over this way. There's Angie.
Sorry.
And she is our director of our admissions department. So that information is right there for you. The phone number to contact her and her team, the fax number to send information, and then the email address as well to send information. So that is all that I have for you guys on the acute, subacute, or the subacute and residential programs. And Angie is here and she's going to talk to you a little bit about the acute programs. Slide in here, I'll move you over so you can see you better.
Hi. All right, so our acute hospitalization is a short-term inpatient stay. These stays are around 3 to 7 days, just depending on the patient and the provider and what the needs are. It is for both male and females. Ages 8 to 17 are on the unit, male and female both. If they are 18, even though they would be in high school, it would still be on an adult unit, okay? The IQ would need to be 70 or higher as well. And just certain things need to be present. So for an acute hospitalization to meet criteria, you would have to be suicidal, homicidal, currently, could not commit to safety. If they were saying that they were not suicidal, there's other circumstances that they would look at, such as if they were giving away personal belongings, if they were isolating, certain indicators. They take all that into consideration. A physician would review the information once an assessment is completed, and then they actually make the determination if they meet criteria or not. So other things are, they talk about feeling trapped or in unbearable pain. We need to go to
Tiffany, you can, yes, let's, thank you.
Thank you.
Tiffany's handling the slides for us.
Thank you, Tiffany. So although the youths are assessed on an individual basis, there are questions that can be asked to help understand what the current crisis situation is. So things that we would want to ask is, have you ever thought about hurting yourself or anyone else? How often have you had these thoughts? Have you had these thoughts recently? And when you've had these thoughts, do you have a plan, or how would you do this? Talking about wanting to die or kill oneself, looking for a way to kill oneself, such as looking online or obtaining a gun or weapon, or talking about feeling hopeless or having no reason to live. Other serious risks that we want to look at as well is talking about feeling trapped or in unbearable pain, talking about being a burden to others, using or increasing the use of drugs or alcohol, acting anxious or agitated, and to a point to where it's very noticeable, sleeping too little or too much, withdrawing or feeling isolated, showing rage or talking about seeking revenge on others, displaying extreme mood swings.
And I was going to add on that, on most of these things, if, for example, the sleeping too little or too much, it would be a change from what they've normally done.
Yes.
So any of these where you're looking at serious risk, these things are different than what their norm is.
Yes. And it would be a new or recent crisis event, usually something that's happened within the last 24 to 48 hours. There are some kids who actually have suicidal thoughts on and off, but this would be a change or a trigger that has worsened that thought to where that they would actually attempt to take their life or have made steps toward taking their life. So things such as a recent loss or trigger anniversary of a loss, such as a death of someone close or a breakup. New social stressors such as grades or changing in schools, bullying, change in family dynamics such as divorce, going into foster care, a parent going to prison, recent trauma such as sexual abuse, rape, physical, mental abuse, or neglect. Some of the warning signs that you can look at is withdrawing from family, friends, or from social activities, changing in eating habits, changing in sleeping habits, giving away prized possessions, drug or alcohol use or increased drug and alcohol use, decline in school or group activities, neglect in appearance that's not typical. And again, the same as with the residential programs, the contact information would still be the same. You would want to contact the admissions department, and the information, one of the direct numbers is on there, as well as the fax or email address.
All right, I think is that your presentation, my dear?
Yes.
Do we have any, and you can have your immediate questions. If you have any immediate questions for River Park directly, you can ask them now, or you can hold it till the end. Either way, it's fine. Feel free to put anything in the chat that you want. This is just a quick overview for you so that you know what you're looking at and what happened. So if anybody has questions, you do have the ability to unmute, or you can type them into chat as you're comfortable. And like I said, we will be sending the slides out. Do we have anything immediately for either of the Angies or Leslie before we swap over to Highland Hospital? Okay, Brad, and for the acute care, is there an IQ of 70 or higher needed? I'm not sure if you all can see chat, but Mariah
Yes.
is asking that. Yes. And I think that has to do, Leslie, you all can answer this better than I can, Brad and Chad and Leslie and the Angies. But I think the IQ of 70 has a lot to do with probably the Hartley Act and some things along those lines, which may or may not be familiar to some of you on the call, but it's basically legislated and it's a legal issue, if I'm understanding correctly, right, Angie?
Yes, that is correct. In addition to that's a specialized population when you go IDD. So that's a bit of a specialized population, and we just don't really offer services that direction to really help them.
Okay. Any other questions? I'm gonna go ahead and Brad and Chad, you're on deck. I'm gonna go ahead and get your slides up. See if this works. Hang on a second. It's going to take me just a second. I have to close one and get the other one open. There we go. Okay.
Yep, I can see it.
Okay.
Can you hear me okay?
Yes.
Yep, I can see it. Just tell me when you're ready.
Will. There we go. Ready for you now. Okay.
It's perfect. I'm Brad Story. I'm the Director of Business Development here at Highland Hospital. And this is Chad.
Hello, I'm Chad Clagg. I'm the intake director for Highland.
And a lot of this that you hear from us is, obviously we're both psych hospitals, so the criteria is going to be the same. So we're not going to get into the weeds like they did. We'll kind of just, high level stuff and reference back a little bit to what they've said. Or we spoke to River Park, before this meeting, and kind of decided to do it that way because we didn't want to repeat everything they just said, because criteria is pretty much the same. Okay. All righty. We are located in Charleston, West Virginia, been here over 60 years. Go ahead. So services that are available, acute services and residential services. For acute services, I'll let Chad go in a little bit on that.
Well, and like Brad said, I don't want to just repeat everything that Angie had went over there at River Park. We have acute psychiatric services for children and adolescents ages 10 to 17. Our average length of stay is anywhere between 5 to 7 days. Of course, that could be longer or shorter depending on the patient and how they do. We do take both males and females. We also require an IQ of 70 or higher. We don't necessarily specialize in IDD or autism or anything like that. The main criteria is threat of harm to self or others, self-harming behaviors, and like they had went over before, things that symptoms of depression or anxiety or psychosis that really present a problem with their daily functioning. So our intake department here at Highland handles all of the referrals, and they will staff those with the on-call physician and make a determination for admission. And here is the information for our admissions process. We've got somebody here 24/7. Our telephone numbers 304-926-1600, option 1. Got the email address, which is a little tricky because it's got 2 S's right back to back. It's admissionsstaff@highlandhosp.com. And we have 2 different faxes. One is traditional and the other one is an electronic fax, comes to all of our emails. Again, here's the signs and symptoms, basically the same thing they went over. Any issues sleeping, mood changes, the sleeping problems can go either way. They can be not sleeping or sleeping too much. Whatever is just a major change from what their normal behavior is. Relationships are starting to sort of fade away, kind of tend to be more loners, losing friends, not getting along with people they used to, excessive fear, just acting in, they don't want to go to school, they really don't want to go anywhere, isolating, and then obviously wanting to hurt themselves or die.
And I will kind of piggyback off that for 1 second. Anytime you do have a referral, in that slide, it does say that we, take referrals, phone calls, via fax, walk-ins even, but we do encourage everyone to call, ahead of time if you do have a referral, because what we don't want to happen is someone just to show up and we don't have an open bed, and we don't really have places for folks to just sit around and wait on a bed, and more likely they're going to have to go to an ER if they haven't. Yeah. And obviously that's not what we want to happen, but it does happen from time to time. So we do encourage everyone to give us a call if they do have a referral, so we can, let you know kind of where we're at with the bed opening or, that kind of thing. Sorry, just kind of went through. For a residential program, we have it's called the Bound for Success program. It's a trauma-based program, and you can go ahead. Yeah. It's a 15-bed residential treatment program. We do accept males and females. Ages 10 to 14 is usually, where we stay around. That's usually the need for the most part. We have taken, a little bit younger than that, but it has to depend on, who's on the unit now and their age and everything else. So we take all that into accountability. Average length of stay is 3 to 9 months. It could be shorter, or it has been longer than 9 months, but very rarely does that ever happen. IQ, same thing. You got to have an IQ of 70 or higher. We won't take anything lower than that, just for the simple fact that we don't specialize in anything that folks with IDD, autism, or anything like that. Usually for this program, outpatient services has has failed in-home services like wraparound, safe at home. Sure, they usually have a couple of short-term acute stays within that year, and for more than that sometimes. None of that seems to be working. Then usually, residential will come next. Even when it comes to insurance approvals and stuff like that, they want to see all those things happen in order for it to be a long-term program. So it is kind of the last resort. It's a program designed for children that have experienced trauma in their life. A lot of the referrals we get now, physical abuse, sexual abuse, a lot of folks within the foster care program there, and also in and out of foster homes. A lot of times in that program, we've seen those kids come through our acute units several different times throughout the years. So we're pretty familiar with those folks. A lot of DHHR referrals, especially. Now for this program, it is a little bit more lengthy referral process. So basically there is an application and we are usually full. So there is a waiting list usually for the most part. But for that referral, you're going to complete an application, submit it to us with supporting clinical documentation. So if there's an IEP in place, a psychological, any outpatient information, discharge papers from previous acute hospitalizations, summary from the therapist, anything that would support the need for that level of care. Once we get all that information, we submit it to our clinical director and our program manager of that program, and they will approve and deny whether they think they can meet the need of that individual or not. And a lot of that has to do with, what kind of acuity we have on the unit right now. So it may be someone that meets criteria, but it may be something that we are trying to not add to the unit, maybe sexualized behaviors or something like that. So then once that happens, we will submit that to the insurance provider and they will approve or deny. And if they approve, we'll schedule admission, put them on a wait list, and kind of keep in touch with them until that opening comes. That makes anything on that? No? Okay. All of our programs are here at the hospital as well. All the referrals go through the intake department, and the intake department will work those accordingly. Again, we don't want to kind of go through everything that Leslie and those ladies went through because it's literally the same thing. They offer a couple more residential programs than what we do, but everything else is pretty similar. And right there is the contact information if you all have any questions or any referrals or anything like that. So, yeah, I think we're good.
All right, I'm going to stop sharing that one. So I have a few questions that will come in and they are not in chat, but substance use in itself is typically admissible or not admissible for acute. My question on that is, my response to that, I think, was just because a student may or may not be using substances does not mean they are also suicidal or homicidal. So can you all explain a little bit about what you see as far as substance use in typically teens is concerned, and whether or not you have programs that are appropriate for that, or whether they have to have that in combination with suicidal homicidality?
Hi. Okay, so for acute, no, they do not have to have substances involved, and it doesn't have to be in combination with. Each person is truly assessed on an individual basis because each person is different. It really depends on, the person. If this is a change in behavior, something to where that you are concerned that their life is in jeopardy, there are serious thoughts, plans in place. They've contacted other people. They have actually went the additional step to basically harm themselves or someone else. So those are the things that we're looking for, something that is a drastic change in their circumstances or crisis.
So
Now,
if
we do have-
if they weren't using substances and then they started, that might be an indicator. But if they had been basically dabbling for a long time and they're not showing suicidal or homicidal ideation, then that may not qualify them for admission.
Right. So what we would look at in that instance would be if it's something that is longer term, we would use the term as more of a chronic behavior, not something that's acute. So if there is behaviors such as substance use that has been chronic, then maybe we need to look at something a little bit more long term. So you would want to maybe look at the 30-day CD program. There's other criteria, and that's Angie's definite area.
Yeah, and for the 30-day chemical dependency program, kids don't always have the mental health aspect that does come with that. Most of the time they do because they are self-medicating, but they don't have to, but they do have to have, again, tried some less restrictive options, maybe a drug court, intensive outpatient, something like that. Because when we review for the 30-day chemical dependency program, we want to see drug screens, how recently are they using, what are they using, and what's their pattern. A lot of people are able to give us the JASI. That's an assessment that a lot of people do use. So we'll look for those kinds of things to kind of see, that pattern of chemical dependency that, maybe a 30-day, I like to call it kind of like a mini rehab. A 30-day kind of mini rehab can help people get kind of back on track, so to speak.
Another question, and Brad, if you or Chad have, just feel free. This is a casual conversation. Anybody who has questions can unmute and jump in. I think the other conversation was if a student or a child, youth qualifies for residential programming, do the guardians have to give up guardianship in order to have that student admitted to a residential program?
No,
For River Park, they do not have to give up that guardianship. Our programs, we do parental placement, basically is what that's called. So we do. But again, that child does have to meet that criteria. There has to be, just like Highland said, that those attempts of less restrictive in-home community types of services that are just failing over, a 3 to 6 month, 9 month time period. You don't want to have a kid maybe try CSED or something like that for like 30 days and then think they need residential. But it can be parental calling us and making the referral and talking to our admissions department as well.
Brad, did you want to add to that?
it's the same thing with us. We do encourage it, honestly, because we do get a lot of folks that have DHHR guardians also, but we do get parental, and it's really good when you get those type of parental guardians. They're usually more involved.
Yeah, success rates are usually higher. Also, when you have that parent involved, that discharge planning that starts at admission, family therapy is just a lot easier and better for that child to be more successful if the parents can maintain. And like, I'm sure Highland does the same thing, family therapy, a lot of parenting education and things like that we offer.
If we have other questions, folks unmute or put them in chat. Otherwise, I'm going to finish the list I've got here. Can you tell me a little bit about whether in acute or residential, do your students receive any educational component?
Yeah, they do at Highland. We have a teacher for both programs. Kanawha County School Board actually employs them.
And for River Park, we do as well. For acute services, we do have a teacher that does some basic types of things with the acute kids. We are more focused on their mental health stability if they are in here for acute suicide, homicide. But we do have a teacher that checks in with attendance directors at their home school, communicates when they have admitted and communicates when they have discharged from us so that there's that flow of communication. And then for residential, we do hire certified teachers. Barbersville School Residential is operated by the West Virginia Department of Education. Our two other programs, Bridge and Roundtable, we hire our own certified teachers. But again, the kids are enrolled in local schools. It's kind of like homebound. And we do all the services here, and we just communicate with a school here in Cabell County where they are officially enrolled.
Okay. And for folks who may have been asking on the side, there are transition coordinators employed by the State Department of Education, typically they're county or regional, and they are charged with working with you to help transition these students. I will say, and this is me being blunt, and I'll be tactful because I'm recording, that it's probably one of the biggest conversations that I hear from schools is, hey, we got this student back and we didn't know they were coming back, or we didn't know that they were in a hospital. And, you know, I know that the hospitals and transition coordinators and folks work very hard to do that. It does require guardian permission to have that conversation because it is HIPAA, you know, Health Information Privacy Act, and I'm going to get all the initials wrong, but you get the idea. So there are limitations to what you can and can't say. Some folks are very open and they want a transition plan in place. And then I've, you know, had other guardians who say, I don't want you to talk to them. And, you know, when that happens, your hands are kind of tied, and it's not the best practice, but it does happen, unfortunately. So other questions, and I'm fine if folks want to keep texting or emailing me, that's fine, I don't mind. But if you are brave and you want to unmute and ask questions, please do. The last question I think I have on my list is, sometimes it seems like there's a very, very long wait for a bed. Sometimes even that's acute. We've had calls where folks say, oh my gosh, I've got a suicidal student. Everybody agrees the student's suicidal. Maybe there's even been a mental hygiene petition or some other sort of court involvement. However, there's no bed. Does that happen a lot on your all's end? Or do you think that that is probably, I don't want to say hearsay, but do you think that that's probably miscommunicated, or is that a typical thing?
So we only have 12 beds available for child adolescent acute population. So it does happen a lot. We do have to turn kids away quite frequently because we don't have the bed capacity for them. We're pretty much staying full all the time. But one thing I want to point out too, as well, is that there is no longer that mental hygiene piece for the children, adolescent population. So they can't be court ordered any longer into treatment like that through a mental hygiene anyway.
Okay, got you. Brad, did you have anything to add to that one?
Yeah, it does happen. It just happened yesterday. We received a call from a counselor and we were full. Yeah, it happens, especially, I mean, it happens all the time.
I think it's really increased during the age of COVID here. So many kids are in crisis and having to sit and wait in ERs. You know, I came to Highland from St. Mary's, and I couldn't tell you the amount of kids that I would see come into St. Mary's and sit in the ER for days, some of them, waiting on a bed to open up somewhere in the state or the surrounding states even. And here, we get referrals from Pennsylvania, Ohio, Kentucky, all over the state of West Virginia. We get them from everywhere, really. I think children's beds are they're hard to come by right at this point.
Yeah, and during the summer months, you'll see a kind of a decline just from schools out and stuff. And I don't know if it's where, you know, they don't have counselors and folks that, you know, call on their behalf or what, or, you know, just things are better, it's warmer, they're out of school. But, you know, winter months, especially January through, you know, right around now, it's pretty tough to find a bed.
So Tiffany, I was going to add, so Highland in Charleston and River Park here in Huntington aren't actually the only facilities in the state that do offer acute services. So you also have Bar H, which is in Beckley. And I do believe they still offer acute services for adolescent, Chestnut Ridge up in Morgantown. Then you have Highland of Clarksburg, which is Harrison County. And then we've actually, and I'm sure that Highland has had to do the same, reach out to other areas in surrounding states to find beds. And Angie, do you know a few of those for them?
Yes. So the Ridge in Lexington, Kentucky, also they will accept West Virginia Medicaid, as well as in Youngstown, Ohio, Belmont Pines. And I know that their beds usually stay full too, because they're kind of in the same predicament as us. However, you know, another option is another option sometimes. So at least it's something that could be available.
That was actually fabulous, because that's the last question I had. And we do have something in chat. Stephanie says, I've ran into this issue on numerous occasions. What is your recommendation for the situations where River Park or Highlands does not have a bed available? I'm assuming it would be contact one of those other 3 to 5 agencies. It seems counterproductive for us to have them sent to the ER, but then they get discharged and sent home. Or are you aware of particular ERs that are more sensitive to the situations that they could then connect with in order to hold students and or youth until a bed becomes available? So it should be open in chat if you need to review that. I read it really fast.
So there are quite a few ERs that we try to work with. I mean, any and all, but if someone is calling with a crisis call, I know the ER is not the ideal place to go. However, if there are no beds available and it is the closest place and safety is the most important thing, then that's what that we always ask that they do. Go to the nearest ER or call 911 to make for sure that everyone is safe in that situation. And then we would, you know, they could reach out from there.
Yeah, it's pretty much the same thing. I mean, it isn't that ideal situation, but it is by far the safest. There's just not enough adolescent beds in the state. There just isn't, and a lot of times everyone's full. But there's no like specific ER that, you know, we would recommend to go to, because they all. I know with River Park too, we work with all of them from Berkeley County down to, you know, Lewisburg and surrounding states. So it's, you know, as long as they're safe is the main focus. And it may be a day or so before we can get a bed, but usually a couple of days we're able to maybe, you know, get an opening. It just depends, honestly.
Well, and a lot of the ERs will work with, especially here locally in the, you know, Kanawha, Cabell County areas, surrounding counties. They'll work with Prestera's mobile children's crisis program. A lot of times they're pretty helpful. They can even, you know, reach out, try to extend referrals out for kids that are stuck in ERs. But one thing I did want to kind of mention also is Highland here in Charleston is not affiliated with the Highland Hospital in Clarksburg. So just because we may not have any beds doesn't mean that they don't. They're not. The two companies are not affiliated whatsoever. So
We know it's confusing.
yeah.
Yeah. In most places, most counties are, you know, are getting mobile crisis. So it's, or they're in effect now. So, you know, that might be, if you're having a county that's had run into that issue, you maybe want to reach out to those folks too. We hear from a lot of those guys around the state.
Yep. And so in chat, along those lines, you all picked that up perfectly. There's a website. There is a children's crisis and referral line. It will link you to a mobile crisis unit, West Virginia Mobile Crisis Unit. These folks are correct. If you've had an interview or an assessment with my team, then we have mentioned this, that one of the first things we do as part of your plan in a school or in a community agency, if you don't have crisis services yourself, is to link you with the mobile crisis unit. That's their charge. That's their grant to do that from the state DHHR. And I believe we have a DHHR person online. You're welcome to speak up if you'd like, but there's the website. It's help4wv.com. And the referral line, most of the guardians I've talked to have said they receive some sort of linkage and follow up within 30 minutes, which is pretty good, considering that, you know, we didn't always have that reputation in West Virginia. So I think it's a good resource, but you have to call it because these folks may not be able to take folks immediately. So it might be a pathway in. Thanks, Stephanie. That was a great question. Any other comments before we close out today? If you want to speak up or ask a question, now's the time.
Hey, Tiffany, it's Grace.
Okay.
Hi, I'm a new school administrator, and one of the struggles that I've had this year is I have a few students who have some severe behavioral issues, and we just struggle to get the right supports for them. Our county is very limited with resources, and some families have access to outside support. Some are very hesitant and reluctant to get other supports other than just referring them to the Help for WV information. Is there anything that you could offer as support for us at the school level?
So there are lots of school-based programs. I know you're in Braxton, so I know where
Yes.
you're at. I've known Grace for a little bit. So a couple of things I would do is I would look at the Help for WV. I'd check out the website. There is a West Virginia 211 program, which is you've probably been connected. Grace, you know most of these things. So what
Yep.
I would probably do in your area is I would do the thing where I get the DHHR folks on the phone and I'm on the phone and I literally contact every mental health provider I can find in your area and ask them if they're willing to partner. That's what I would do. And so I may have a lead for you. So what I might suggest is that we follow up with if Mr. Kiefer's on here from DHHR. I think he was. I'm not sure if he still is. Yes, he is. So we may follow up with him and yourself and me and just throw the dice and see if we can get anybody to play ball up in your area, if you're open to
That
that.
would be fantastic.
I had one CEO that did respond when I asked her if they could cover Braxton, and it was a maybe, which was better than a no. So we'll take that.
All right. Thank you.
All right, Grace, I'll send you an email on that. Okay.
Thank you.
Okay. Any other comments or questions? Grace, I'm going to mark this as a follow-up.
And this is Brad. I will say this too. When it comes to, this is more of a residential thing that, you know, we'll get calls a lot of time and it's basically last resort calls or, you know, kids that hasn't had any kind of outpatient services. You know, if you do have kids that, you know, are struggling and you feel like outpatient services is needed, then make sure that you try to get those, because a lot of times when it comes to residential anyways, sadly insurance will just not, well, they won't pay if there's no, you know, outpatient services that has been tried beforehand. And a lot of times it's there's calling like, you know, I'm at my wit's end, I don't know what to do. You know, they're you know, it's gotten worse. So, you know, try to really take those steps before it ever comes to that. I know a lot of times you all are just advocates more so than, you know, you can't getting the guardians to actually do what they need to is a struggle in itself. But it is super important because a lot of times the insurance providers will sadly deny those kids.
Tiffany, I'll add on to what Brad was saying there with the insurance and treatment. They're always going to want the less restrictive first. And the residential programs that we have are the most restrictive programs in the state. So they're going to want them to try other options before they would come to that. And really the same thing with acute care. If they've not had any outpatient treatment at all through something like Prestera or Westbrook or some of the other facilities that are out there, then that's what we're going to want to see them get that outpatient treatment first, if at all possible, so they get that less restrictive, unless of course they're having an attempt. Then we definitely want to do what we can to help them out. And then the same thing with those residentials. What the insurance looks at is if they've not had any other treatment, then why do they really need this high of a level of care? So they definitely want that less restrictive first, such as an outpatient or even a lower level residential prior to being in such a restricted environment.
And there are place called intensive outpatient. They are few and far between these days. So as a matter of fact, I'm not even sure if there are more than a couple still functioning in the state. So, but some of you might know them as on-site alternative type schools where they offer therapy, which would be group or outpatient therapy. And that's kind of what they look like. So you may not know them. Intensive outpatient is not a word that we say. Everybody knows them by the CHANCE program or by something along those lines. So if you're lucky enough to have one of those in your area, trying it first, generally, as long as the student isn't actively homicidal or suicidal, is an option, like Leslie said, and outpatient. And I'll be honest, Leslie, what we're seeing, and Brad, what we're seeing a lot is even the wait to get outpatient therapy can be very long, unfortunately, recently. So, but there are folks who are out there and they are trying very hard to hire people. I can tell you that.
Yeah, we're facing, and I'm sure as everybody, the school system, I'm sure is facing the same thing. You're dealing with trying to get the workforce shortage on staffing and things like that. And so we are all struggling with that as well.
And I will say one more thing too is we talk a whole lot, us, River Park, Highland, Clarksburg, Bar Age. So we're always trying to, especially when it comes to open beds, that kind of thing. And even when it comes to residential, referrals, that type of thing, we all communicate. So it's, even if we don't have a bed, a lot of times we'll know who has openings that day. And we do try to, if you do call, we don't try just to hang up and say, no, we don't have beds, bye. We do try to give you some information or some leads if all possible. And that doesn't mean that they're going to have a bed still open, okay?
Yep, but if you don't communicate, you won't know they need one. So I understand that. So, all right, we are at 1:54. Any last comments or questions? Feel free to unmute and speak up. Like I said, it's your last chance. And if not, we'll ask for any last comments from River Park or Highland. Pretty quiet. All right. Any last comments from anyone before we close out today? And we want to thank you all for coming to present with us to give an overview of your programs. Thanks, everybody. We'll send out the PowerPoint and a link to a survey. Have a great day.
Thank you.
Thanks.
Thank you all.